The Moss Report is brought to you by Mycolife, makers of the world's best mushroom extracts, including the Moss Method mushroom formula, available exclusively at mycolife.us. Hello, healers. My name is Ben, and this is the Moss Report. I'm here today with my father, Dr. Ralph Moss, and our special guest, Dr. Dennis Holmes, who has a practice out of Glendale, California. And we're very interested and excited to meet with you, Dr. Holmes. And I first want to take a moment to introduce the two of you. I don't think you've ever met or corresponded.
No.
Well, there is some definite common ground here in that your practice focuses on cryoablation, something that we have a longstanding interest in, both from our platform and what we talk about, less toxic, more natural ways to fight cancer, but also from a personal side of things, with my father having been the recipient of that type of treatment. So I'm really looking forward to hearing the conversation that you two have and hearing more about your practice as well and what brought you to it.
Of course, I've known about you for many years. As Ben said, we have a special interest in this topic of cryoablation. I think we're on the same wavelength in that we cherish treatments that could be less invasive, less traumatic for patients. That's sort of the bottom line. It doesn't matter to us where they come from if they can be scientifically validated and also be kinder and gentler on the patient. Then, we want to do our little bit that we could help publicize that. And also, as Ben mentioned, 10 years ago, I was treated with cryoablation for prostate cancer. That experience was mainly a very positive one and confirmed what I think and thought about that procedure. I think our audience would like to hear how you transitioned. Here you were trained as let me see if I got this right. You'd gone to Tulane Medical School, right? And then you trained at UCSF, University of California, San Francisco, as a general surgeon, right?
You have it exactly correct. I started as a general surgeon, and as breast surgeons usually do, many of us specialize after a full general surgery training, and so I did a breast fellowship. And while attending a meeting as a breast fellow, as a breast surgeon trainee, as we would call them, I attended a meeting that covered a range of topics, but one of the topics that I heard about was cryoablation, tumor freezing. It was kind of a new approach that was being evaluated at the time for treatment of benign breast tumors. And during my training as a general surgeon, I had the opportunity to treat many patients with breast cancer because many general surgeons treat breast cancer patients. And I would frequently hear comments from patients about the concerns of the treatment. Of course, they fear the diagnosis of breast cancer, but they often express concerns about the treatment, the impact of surgery, the impact of radiation on the breast, and the impact, the potential quality of life impact. And so I was open to listening and problem solving. And when I saw this presentation about cryoablation for benign tumors, I said, well, that's a great idea, but it's an even greater idea for cancers, for women who want to avoid surgery, who might have tumors small enough to allow that treatment to be performed. And so when I finished training, I immediately set about learning how to do cryoablation for benign tumors because that's all we could do at the time. But I did it as a training ground so that I could one day transition to treating breast cancers with cryoablation, which is what I do now. Now, I'm still a surgeon. I'm a breast cancer surgeon. I specialize in the treatment of breast cancer, and I still perform surgery every week just as I do cryoablation. But, the point is giving patients a choice, giving them an option. And in the context of patient-centered care, we need to have treatment options for patients that want to have minimal therapy, as well as those who would prefer to have a mastectomy, or what you might consider as maximal therapy. Cryoablation, I think, is a very important strategy for offering women a less invasive, less morbid, more convenient treatment that in many cases is as effective as surgery. So I'm privileged to be able to offer that now as a routine procedure. But the journey began 25 years ago, when I first learned about this procedure at a meeting.
You mentioned in one of your interviews that there were 3 people in your family, basically, who got cancer within a 2-year span. And I'm wondering how that all played out for you, how that influenced your decision to pursue that path.
Well, it was both very untimely and timely in a sense. It happened during the middle of my residency. I had my mom, my dad, and my spouse all were diagnosed with cancer within a 2 year period. None were breast cancer diagnoses, but they were, and two survived and one didn't. So it was quite dramatic time. But what it did was it made me much more open to listening to what patients were willing to have and not willing to have. Even if it could offer you a treatment that had a cure, but if the treatment were morbid, some patients would decide, well, I'd rather not have the treatment. I can be at peace with that. So it helped me really appreciate the patient-centered approach of finding treatments that were right for the individual patient. And through that experience, kind of in the position of the family member, I wasn't the physician at the moment. I mean, I was in training, but at the moment when I was accompanying a family member to an office visit, I was like the patient. I was
Yeah.
having to listening and weigh these pros and help them weigh the pros and cons of treatment. And so it really kind of tuned my ear to listening and knowing, yes, we can do all these things, but are all these things the right thing for this individual patient? And what are her values or his values? And how can we help them find something that makes them feel whole and complete and preserve their quality of life, as much as possible.
So this is really about freedom of choice for the the patient and the patient's family.
I remember, very early, quite a number of patients who developed a symptom or were diagnosed with cancer, but delayed the treatment. They delayed the treatment because they only knew of what they perceived as the bad treatment, the mastectomy, the chemotherapy, the radiation, the things they wanted to avoid. And so delayed treatment until that was really all that was available to help them. And so the problem solving, like, how can I develop my career as a breast surgeon? My first principle was I want to help develop treatment options that are less morbid, that will kind of open the door to treatment as opposed to repel people from treatment. So cryoablation is one of the things I was involved in. I've been involved in other innovations as well, but it was definitely, something that I thought would facilitate treatment for those who wanted treatment and for those who, it doesn't solve every problem. And for some who may want to do surgery, maybe they want to do surgery this time, but the next time they have a problem, maybe they don't want to do surgery. So it really is about giving patients options. And again, no treatment is the right treatment for all conditions, but there are many patients, especially for those with early stage breast cancer, who can be treated with a minimal procedure like cryoablation or a lumpectomy and go on to live a full life with minimal impact. So it is really about choices and giving patients a pathway. I would make one other point, which is that sometimes patients fear not the surgery or the cryoablation, but they fear the medication or the radiation. But the idea that they have to do all those things together is a barrier that they won't cover. But if you could sort of parse it and say, well, we could set aside the radiation treatment question or the chemotherapy treatment question and focus on, the most immediate problem, which is putting out the so-called fire, putting out the problem that they're currently dealing with, which you can do with cryoablation, then at least engages the patient in care at some level. And if they decide to add something more later, that's supportive. But the primary focus is to deal with the immediate problem, the cancer that's growing in the breast. And cryoablation does allow people who might be opposed to the idea of Western medicine to get some foothold into treatment that's effective and that's proven to be effective, especially for early stage cancers.
There is a scientific study that you were co-author on that showed that people who delayed having treatment by, I think, 2 months after the diagnosis have a significantly greater chance of having disseminated or advanced breast cancer. Am I quoting it correctly?
You are correct. It's interesting how all these things come together because,
Yeah.
my initial mission was to, offer treatments that facilitated care because they were less morbid. And now at this point in my career, I'm spending actually quite a lot of time thinking about solving the problem of delay of care because we now know, mostly from the data that's been produced in the last 10 years, that a 60-day delay is associated with a reduction in survival, especially for breast cancer. The basic formula is, if you look at a 30-day period from diagnosis, so from your biopsy today and within that 30-day period, that's the ideal period in which to be treated.
Yeah.
If you can't, 60 days would be better, But beyond 60 days, we begin to see a survival reduction, about a 10% relative reduction in survival for every additional 30-day delay. And
Oh,
it's pretty, and it's not unique to breast
that's
cancer. Breast cancer was
yeah.
the first cancer for which this was clearly defined, but it's true for many cancers, colorectal cancer, lung cancer, etc. So we now know, and there's many sort of pressures now to be more persistent in pursuing treatment. The College of Surgeons, American College of Surgeons, which I'm meeting them attending this very week, established new guidelines recommending breast cancer treatment to begin within 60 days of diagnosis for that very reason. And so, you know, lowering the barriers to treatment will facilitate that. There are logistical navigation barriers, patients having challenges getting to treatment and whether it's transportation or ability to get an appointment. But there's also the barrier of the fear of the treatment, which doesn't exactly motivate a lot of people to schedule their appointments quickly. But awareness. Some people think they have infinite time to try many things. Certainly, they have the freedom to make the choice to try things. But if they know that time does matter, they'll be a little bit more deliberate in what they try and more intentional about seeking some treatment like cryoablation if it's available to them.
One of your papers that fascinated me the most was a recent one on the fear. We're back to the fear factor, but the fear that many women have of spreading the cancer through the biopsy, something that we've heard infinite number of times. It comes up constantly in our discussions with cancer patients. And why don't you talk about that? Because that's sort of like the third rail, isn't it?
It is.
To use a New York City metaphor.
So,
But go ahead, talk about that.
I've heard about it many times, and I decided that I needed to address it. And so I did research. I looked at various cancers and the data that have been published about the risk of cancer spread through needle biopsies, and there is certainly some truth to that, but it's a marginal concern in terms of its actual impact, meaning that it may happen, but it happens rarely, or it might happen, but that doesn't mean that that cancer cell is able to survive and grow and cause harm. So, in essence, we feel that the clinical impact, meaning that does it really impact people's outcome, is so small that it's not really a concern that should drive the behavior of most patients with diagnosed with breast cancer. I'm not saying this is not an issue for other cancers. I'm saying for breast cancer, that people who are truly harmed by the biopsy procedure is very, very, very small. However, that doesn't mean they aren't concerned about it.
Yeah.
And because there's still some legitimate concern, many people delay the diagnosis of cancer. They feel a lump, but they don't want to have it biopsied because they fear spread. But while they're fearing the spread, it grows and it spread. So we're kind of in a catch-22. And so
Right.
I decided that I needed to kind of help problem solve this, that to help people get over the hump, because I didn't want them to delay treatment while, because of concern to spread while allowing it to spread anyway. So I developed a technique whereby we're able to utilize cryoablation along with some other technical approaches to minimize the potential of spread or deal with spread if it were to happen. For example, one concern is needle tract seeding. Like when you introduce a needle into the tumor and you remove the needle, there's concern that some of the tumor cells might get displaced along the needle tract and then remain and potentially grow. And yes, that can happen, although it doesn't necessarily impact people's outcome. But one way you can address that when you do cryoablation is you can do the biopsy and then freeze the entire needle tract. So that if something survived with the needle tract, we could freeze it. And so that gets people over the hump sometimes when they fear the potential for tumor spread during a biopsy. The other is, the potential for cells to move about, kind of to escape the tumor in other ways. And so we basically inject, a solution of lidocaine and epinephrine around the tumor, which kind of causes the blood vessels to sort of constrict and holds things in place. So it's a combination of these sort of technical procedures and cryoablation procedures that we can at least, for an individual patient with this concern, tell her that although this is theoretically possible, there's a way for us to minimize the potential harm of spread that hopefully will help her feel more engaged and willing to go forward with treatment. And the last part I would say is, if we're doing cryoablation to freeze a needle tract, if the tumor is small enough, it makes sense just to freeze a tumor at the same time. So we can offer a definitive ablation of the tumor, to ablate the tumor in the margins, while also taking a biopsy sample and freeze a needle tract to minimize the potential for spread. But the biopsy is important. We do need a tissue sample to know the diagnosis, to be able to guide the patient going the treatment. But this approach that I just described does minimize the potential for spread, and that's why it's become somewhat popular.
Not everybody has access to cryoablation. It's still relatively rare. You've made great progress in terms of acceptance, but how would you evaluate the state of the art, as it were, this year compared to previous years?
Well, it's certainly looking up, but you certainly also acknowledge, an elephant in the room, which is, though the cryoablation is available and some of us have been doing it for many years, the main barriers are awareness and the fact that it's not a procedure that's routinely covered by insurance or healthcare. And so it becomes, unavailable to many people who can't afford it, to be frank. But as I said, it's looking up, and I'll address that in just one moment. But, we've done over the last 20 years, in terms of the state of cryoablation, a number of clinical trials. I'm conducting one on a particular type of breast cancer now, but we've conducted clinical trials that have demonstrated that it is an effective treatment with low recurrence rates. Trials go out as far as 5 or 6 years post-treatment for early stage breast cancer, and they primarily show recurrence rates that are about what you get with lumpectomy. So the science is actually sound for these early stage breast cancers, but just because it's available, it doesn't mean that anyone can access to it, especially when the procedure is not widely performed and when there's maybe some, there may be for some financial considerations. But I would like to say that just last Friday, the FDA finally approved on contingency, the use of a particular cryoablation device to perform breast cryoablation. This has been long awaited. We've been working at these trials for 15 years to get enough data together to get FDA approval. Now, FDA approval doesn't mean insurance coverage, but that's the first step. And we do know that for Medicare patients, if they go to a place where cryoablation is offered in the hospital setting, that some patients are able to access cryoablation because Medicare does allow coverage of one component of the cost, the device cost. It just doesn't cover the professional cost. So it's not really a financially viable option for many hospitals to offer it if they only get paid for a fraction of the cost, and it's a relatively small fraction of the cost.
Yeah.
But for those who are able to afford it, the treatment is available. There are a number of surgeons and radiologists around the country who offer it, and patients may have to travel to it. But the most important part is to know that it's an option. If it's an option that's important enough for you to pursue, it's quite accessible. In fact, we primarily treat patients with early stage breast cancer, stage 1 breast cancer, which is what most of the data address. But for those with more advanced stage breast cancer, stage 2, and some patients with stage 3, we're also able to adapt the technology to treat those. And that's what I have been focused on a lot over the last 5 to 8 years. The clinical trials that I described a moment ago primarily focused on women with stage 1 breast cancer, and in particular breast cancers that were 1.5 centimeters or smaller. But many cancers are larger than that. And I wanted to at least preserve the option of treating larger cancers. We know from other cancer sites like liver cryoablation or prostate cryoablation, other sites that you can do multiple ablations simultaneously to treat a larger volume of tumor. So we basically developed techniques for breast cancer whereby we can treat a tumor that's larger. The size limitation is primarily due to the fact that when we do a single cryoablation treatment, we can generate an ablation zone, a kill zone, about the size of a walnut. So if we, in selecting cancers, we basically have chosen cancers that would fit nicely within the walnut with a rim of normal tissue around it, what we call a margin. That was kind of the kind of lowest hanging fruit, if you will. That's why the 1.5 centimeter tumors would fit perfectly within the size of a walnut to allow treatment of the cancer and a margin. But if the tumor is larger than 1.5 centimeters or can't fit nicely within a walnut size area of ablation, we have the ability to use multiple overlapping ablations to cover a larger tumor. And that's the technique that I'm referring to. So if the tumor is, say, 2 centimeters or 3 centimeters or 4 centimeters, we would need to have multiple ablations to encompass that tumor and a surrounding margin. Some people have lymph node involvement involving maybe 1 or 2 lymph nodes. And if they're unwilling to have surgery, we can perform cryoablation of those lymph nodes to eliminate the need for surgery of those lymph nodes and, of course, kill the cancer that's within them. Those with more extensive lymph node involvement aren't really great candidates for cryoablation. They have a greater need for surgery. But for stage 1 to early stage 3 breast cancers, in most cases, we can manage those cancers with cryoablation using this combined approach of multiple ablation zones. So to put together, I kind of refer to them like the Olympic rings, where the 5 rings overlap. You can sort of overlap the ablation zone in a way to cover, a tumor of almost any shape or size within the breast.
Would that be in the same session?
Yes. There are 2 strategies that are used. Some radiologists use a technique where they place multiple probes simultaneously and then treat in one treatment with all probes present at the same time. The technique that I use is one in which we place the probes sequentially. So we freeze one area, and then we freeze the next, and then we freeze another. But it all happens in the same procedure. And by freezing, one area immediately after freezing the other, we can actually sort of borrow from the freeze. The breast is colder, so it freezes faster and freezes better. And then we simply relocate the probe from different angles to cover a cancer. They're not all perfectly round. Some are quite regular. Some have multiple, like little satellites or adjacent masses. So we can basically arrange the ablation zones to encompass all those areas plus a margin.
You wrote a paper on doing this during COVID. That must have been very challenging.
For a decade, I've been this advocate of for timely treatment, avoiding delays in treatment. So I couldn't in good conscience tell people, wait, until the pandemic is over or whatever to come to treat your cancer. When I knew the data, I was one of the first people to sort of really focus on this problem. So I was definitely aware of the harm of delay and didn't want to be complicit in that. And so my hospital, fortunately, although they delayed many elective procedures, they allowed us to continue to operate and do breast cancer surgery. So that was one blessing. But another blessing was that, cryoablation is done in my practice within my private office.
Oh.
Office is on the medical campus, but it's within an office. It's not within the hospital. So I had the ability to regulate, whether or not we offer the treatment or not during COVID. And so we did. Now, what's interesting further is that, I'm the member of the American Society of Breast Surgeons, and they, like many other societies, took the position that, we could delay cancer treatment, and utilize these strategies to delay cancer treatment. And I was thinking, and I actually had to challenge my own society in this paper. It's like, well, you can delay, but you don't have to. And in their paper, they didn't consider that cryoablation is one way to manage cancers, to either treat them or temporize them in a way that you could, deal with the growing mass within the breast. And so I published a paper as a challenge more to the societies that are saying delay. I would say, well, delay is one option, but, you can do better. And cryoablation is a way that you can treat a tumor that, as a definitive treatment, like you could treat it without the intent of offering any further treatment in the future because it's effective, or if it's a tumor that ultimately might benefit from surgery, you can at least temporize it by killing most of the disease within the breast, even if you can't give them chemotherapy at the time or radiation time. You can put out that sort of deal with the main mass. And so that was the context in which I published this paper, about the role of cryoablation in the context of a pandemic to facilitate care for patients who were diagnosed with breast cancer.
What was the reception of the article among your colleagues?
There was actually not much pushback, fortunately, but it's not a skill set that most people have. And fortunately, it didn't cause any strife. It worked out. It worked out fine at the end of the day. But it was important, consistent with my mission, to make sure that people had a path to accessing treatment, and one that would soothe them. And so
Yeah.
it was just consistent with the behavior that I've displayed repeatedly throughout my career, and also consistent with the idea. My own personal philosophy is raising the standard of care, not practicing the standard of care. So there's always a standard of care, but it's not necessarily the best. That we always want to lean forward and improve things. And so cryoablation, even in the pandemic, is consistent with raising the standard, offering options that are better than what's otherwise available.
Seems like the other big idea in terms of your career is intraoperative radiation therapy, which is intriguing because, as you state at your website, it's the difference between a 30-minute treatment and a 30-day treatment. So that would seem to be, if the results are equal or equivalent, sort of a no-brainer, right? I mean,
Well, now you're on to a controversial topic, but I'm happy to discuss it.
sure, that's what we're here for.
I have a little controversy. So, you know, it was another thing that I heard about. I mean, even more than surgery, I hear fears that patients have of radiation, and that was something that was quite common to hear about when I was in training. And so, I learned about early in my career this clinical trial that had initiated in Europe, but was to be extended to the U.S. In fact, it was ultimately conducted in 33 countries, but we were one of the early countries to join the trial. And I was one of the early investigators to join this clinical trial evaluating the use of a single dose of radiation given at the time of surgery as a substitute for the 30-day course of radiotherapy, which was standard at the time. And this surgical approach the approach that was used in surgery was called intraoperative radiotherapy, or IORT for short. So it was a trial of IRT versus standard radiotherapy.
Meaning that, for people not aware, that the radiation delivered in the midst of or right after removing the tumor, you give while the patient is still open, as it were, you give them the radiation right on the spot, right then and there.
Thanks for that clarification. So it's surgery. It's performed a lumpectomy surgery with the radiation given immediately at the time of the surgeries. Meaning we take out the cancer, it leaves the cavity, we introduce a device into the breast, and we give the radiation to the margins. That's intraoperative therapy. And that was the new technique that was to be evaluated in the trial. The traditional treatment is a type of radiation that's given to the entire breast. It's given after surgery. It is given daily over a 30-day period. So it's a 30-minute treatment during surgery or a 30-day treatment after surgery, as you referenced moments ago. And so this is a randomized trial, over 2,000 women. 1,000 got IORT, 1,000 got standard radiotherapy, and we followed those patients for an average of 8 years, but the longest patient was in the trial 18 years.
Ooh.
And we proved that single dose intraoperative therapy was as effective at reducing recurrence in the breast as standard whole breast radiotherapy. It was a tremendous accomplishment by investigators around the world and patients who joined the trial, which we couldn't have done it without the patients. And so it's a procedure that I offer now routinely. Every Tuesday, we do these procedures. The challenge is, and that's where the controversy lies, is that radiation doctors get paid by the number of treatments that they give. So if they're giving 30 treatments, that's 30 payments. If they get intraoperative radiotherapy, it's one payment. And so we had a tremendous amount of resistance from the radiation community. So it is indeed the case that surgeons were the champion because we dealt with the patients. We had the relationship with the patient. We wanted to offer patients treatment that were more convenient, more less morbid, and very effective. But there was this tension that brew over the couple of 15 years, and ultimately the radiation oncologists, frankly, are winning out because they've done many things to sort of restrict access to it because it doesn't align with their financial with their balance sheet, if you will.
Right.
But it is effective treatment and it is something that I offer patients. And to be frank, I mean, there's an argument and I won't say it's a valid argument, but there's an argument that IRT is not as good as standard breast radiotherapy, meaning that the recurrence rate might be slightly higher with intraoperative therapy, like by 2%,
Hmm.
which is a marginal number. But we give patients the choice to choose between a range of treatments. We can offer them a lumpectomy or mastectomy, knowing that the recurrence rate is higher after a lumpectomy, but we give patients a choice. We give patients a choice to have chemotherapy or not, knowing that the survival rate is lower when you, for certain patients, if they do not do chemotherapy, but still we give them a choice, offering patients the option of IRT versus standard radiotherapy should be a choice, balancing the desire to have convenience and quality of life versus cancer control. These are choices we make routinely.
Yeah.
IRT is not different, but what we have found is that they've been very sort of rigorous. Well, we can't allow these differences, and so therefore we shouldn't support IRT. But it really is a financial argument that's the elephant in the room, and
Yeah.
we have to
There's a
deal with
lot.
it.
In the past, when we've talked with other ablation specialists, one of the topics that we explore interfaces with our ideas of engaging the patient's immune response to help themselves fight cancer. And the subject of what has been called the abscopal effect, where you're leaving the mass in the body, and as it necrotic tissue is being reabsorbed, the body's own awareness of the existence of that cancer seems to be uh, heightened. Is this something that you're aware of that you sort of leverage in your practice or think about how to support the body's process sort of post cryoablation to enhance that effect? Or have you noticed or seen anything that would speak to that?
Well, it certainly is an area of great interest. I've known about it, and it was one of the things that drew me to cryoablation. Uh, the data that showed that treating the tumor with ablation, cryoablation, for example, can uh, enhance the immune response to it. It can release certain proteins called antigens that will expose the tumor to the immune system to enable the immune system to more effectively attack it. Um, at least conceptually, that's what abscopal effect is about. Now, the challenge with cryoablation is, although the immune system can respond to the tumor, then its immune response is heightened. Is it heightened enough to be protective? Uh, and that's where I think there's some uncertainty. There are clinical trials that are actually looking at this question, and the trial suggests that yes, there is a response, but it might not be protective, and it might need to be spiked. Might need to be stimulated by other agents to enhance that immune response. So the take-home message is that there are probably some patients that get a clinically meaningful immune response, but it's also clear that some patients don't get an immune response that's enough to be protective, that it doesn't prevent them from developing a recurrence. That doesn't mean that they don't need to have anti-estrogen medication or chemotherapy or radiation, because if they're tumor cells that have left the breast, in some patients, they still may recur. But it's an area it's of great interest. There's research interest in sort of understanding this immune response so that we can amplify it and get these meaningful clinical responses, life-saving responses that we're not necessarily seeing so readily at this moment in time. In terms of the ablation techniques for breast cancer, cryoablation is the one that's sort of at the lead. But in other countries, and in some places here, they're looking at other forms of thermal ablation, like radio frequency ablation using heat. That's a heat-based ablation. There's microwave ablation. There's high frequency ultrasound ablation. These are all ways of focusing heat at the tumor site to kill the cancer. Cryoablation extracts heat from the tumor site to kill the cancer. The main difference between the heat ablation techniques and the cryoablation techniques is that heat tends to be pain producing, and so they're performed under sedation or general anesthesia. Ice or cold tends to be pain relieving, and so we can perform cryoablation in the office with local anesthetic without the need to provide sedation
Hmm.
or general anesthesia. So you can provide the procedure in a more convenient setting with less potential harm, because we can use simply local anesthetic, just using essentially the same approach that one would use if they had a needle biopsy of the breast, where it's done in the office setting
Yeah.
with local anesthetic with the needle inserted. that's basically the essence of cryoablation. We're just using a needle for treatment as opposed to a needle for a biopsy.
Great pleasure to finally meet you and hear from you personally about your work, and we hope we can continue to follow you for many years to come.
And Dr. Holmes, I want to say at the Moss Report, our primary goal has been to explore and encourage investigation into less toxic, more natural approaches. And cryoablation seems as though it's one of the least toxic approaches that we've heard of. And really, you are to be commended for pushing the envelope out, for standing your ground with what you've seen in your own practice, and helping to move in that less toxic direction the field of surgery for cancer. So, on behalf of our audience and ourselves, we want to thank you and congratulate you for doing that and wish you all the best of success in your endeavors.
Thank you. Well, it's been a privilege to join you today, and thank you for the partnership in spreading the word about the cryoablation and other strategies to reduce the morbidity of breast cancer, since many people are looking for something better, and this is a better option for many women. So
Thank you.
All right. Well, for now, for the Moss Report, I'm Ben Moss. How are you healing today?